coming on to the topic again, sorry for the disturbance. So thin endometrium. So the endometrium, as everybody knows, it's just the lining of the womb. So the endometrium is very important for an embryo to get implanted. So endometrial thickness, the nourishment, and the receptivity are the ones which are really, really important for an embryo to get implanted. Let it be in a normal pregnancy or it might be an IVF conception. So as you all know these facts that healthy seed is just not enough to get a healthy plant unless you grow it in a fertile soil. In the same way, healthy embryo needs definitely a receptive endometrium for a successful implantation. So now moving on to symptoms. Do we really know that, okay, thin endometrium has some symptoms? In our history, can we elicit them? Yes, definitely. Some people might definitely come to your clinic telling you about the abnormal cycles they have, decreased menstrual flow, or a painful menstruation. Or they might just come with an infertility issue, not having any of the above symptoms, or they might not have any symptoms at all, where they come under a criteria called asymptomatic thin endometrium, which can be diagnosed or which is accidentally diagnosed when they come to you for a fertility issue, and then you see a thin endometrium when you do your follicular studies, or a general routine scan when you call them on a day 2 scan and a day 9 scan. As you all know, the endometrium has to grow from day 2 to day 9 and day 9 to day 12. Generally, it is taken as a fact that on day 2 it is supposed to be as 2 mm, and day 9 it is supposed to be as 9 mm, and then day 12 it is supposed to be somewhere around 12 mm. That's supposed to be a good type of endometrium. So what would be the causes of thin endometrium? Low estrogen level. As everybody knows that estrogen is a vital hormone which is really required to nourish and to actually make the thickness of endometrium. If a lady has decreased estrogen levels, they might have thin endometrium. Inadequate blood flow to the uterus through the uterine arteries is one other factor. Poor endometrium health, poor health of endometrial tissue. That might be because of endometriosis, which is caused by PID, that is pelvic inflammatory disease, just because of some infection or inflammation, or a tuberculosis, which is really, really common, which is a genital tuberculosis in India. As per se, they say 40 to 50% of women are affected with genital tuberculosis, as an Indian statistic level says. The recurrent DNCs or too many surgeries which has occurred on your previous surgeries, like when somebody has undergone a lot of DNCs just for a thin endometrium or a thick endometrium or an abnormal bleeding, when they wanted some therapeutic TNC has been done, or it might be just because of some abortions. So these surgeries can also have effect on the endometrium, which can lead to adhesions, synechiae, and stenosis of your cervix. So use of birth control pills, continuous use of birth control pills in a chronic period, let's say 2-3 months, it would definitely not affect the endometrium. But if somebody takes this pill for a continuous period of 2 to 3 years, or 6 months, every 6 months, in case of polycystic ovaries, some people have been prescribing so in such cases, definitely it is going to affect your endometrium. Use of fertility drugs like Clomid definitely has an anti-estrogenic effect, which can cause a thin endometrium. So these are the causes and the symptoms which you can elicit or see in the patient. But how do we actually deal with this thin endometrium? How can we proceed? How is there a diagnostic tool? Yes. So endometrium is an integral part of implantation, as everybody knows. So identification of an accurate marker of implantation would be highly beneficial in ART or in a patient who's struggling to conceive. But unfortunately, we do not have any such markers. Despite of enormous research in this field of human embryo implantation, the ideal endometrial receptivity marker still remains in identifiable, or it is not defined at all. That is where we lack in 40% or 60% of our pregnancy chances have come down even after a lot of research in IVF. And there is a lacunae of not getting pregnant, even we know whether our embryo is a good quality embryo and everything is in place, but still we are not able to achieve pregnancies in multiple IVF cycles. So this might be the whole and sole reason that we are missing out something on the endometrium. So how do we look for it? Lack of accuracy and predictive value and invasive nature of these biochemical tests. So there are only either two types of tests. Either you do a biochemical test or a histological marker or endometrial receptivity, which is an invasive technique. And this per se, like when you're taking a histological marker, you're supposed to do a DNC and send the tissue for analysis. So you, as everybody knows, that endometrium is a different growing thing in different cycles. It's not the same like the previous cycle. So every cycle there's a different endometrial growth. And if this cycle says, okay, it is receptive, next cycle it not be the same thing of endometrial growth. So probably histological markers, if we have to do a DNC every month and take a tissue, it is going to do a more damage than what we are going to treat a patient for. So sonography, definitely by virtue, it's a non-invasive technique wherein every clinic has a sonography machine. So using a sonography, I think we can play a major role detecting thin endometrium and thick endometrium, and where we have to intervene and not intervene. So let's see how ultrasound actually helps us. So ultrasound, what type of ultrasound we should use is, if we have to always use a transvaginal probe. Either a 2D or a 3D can help us. 2D would definitely help us in a routine scan to see the type and pattern of endometrium, and 3D definitely when you're looking into the vascularity, when you're putting a Doppler to see how much blood flow is there till what extent in the endometrium. So we'll be discussing about few things like the pattern of endometrium in the next slide. So this is the pattern of endometrium which you can see. So there are three types of endometrium which you would see in a cycle length. In one cycle, you can just see all these three types of endometrium. So the type A endometrium is the first figure where you can see, which is labeled by type A. And here you can see a nice multi-layered endometrium which is called trilaminar layer, and wherein it is hyperechoic. And there is also an intervening layer in between, which is a hypoechoic layer. There is, the endometrium is definitely hyperechoic when compared to your myometrium. That's how we describe type A endometrium. Type B endometrium, wherein it is almost homoechoic, that's what we mentioned, to the myometrium, and you see a multi-layer pattern even in this type B endometrium, and you also see an intervening layer in this type of endometrium. And type C endometrium, wherein it is an isoechoic, wherein it is almost the same echogenicity as that of the myometrium, and there's no intervening layer in between. So that is the type C endometrium. So these are the three types of endometrium which we see throughout the cycle. Type A, we generally see from day 2 to day 9 or day 10. And type B is mid-cycle, that is somewhere around day 12 to day 14, when your egg is absolutely ready for rupture and to release an egg. And type C is the endometrium which you see in a secretory phase post-rupture of your egg, when you see a nice corpus luteum sitting in the ovary. So these three types of endometrium is the one we have to see when you undergo scans for follicular study. And the thickness definitely on the day when the egg is ready to release, I would definitely say that the thickness, always take the thickness from outer layer of the endometrium to the outer layer of the endometrium, just 1 centimeter below the fundus. That's where you have to measure the endometrial thickness. So, and when you measure the endometrial thickness, it is always a sagittal section, it is not a transverse section. And then you have to see the endometrial lining from the cervix and till the the fundus. The whole endometrial junction should be seen. You cannot just focus only the fundal part of the endometrium and take the measurement. Then probably we might get a thicker endometrium and be happy with it. That's not the way we have to measure. So these are the three important things when you see a type B endometrium, which is really nice to look at when an egg is getting released. Coming to the blood flow pattern, this is how a color Doppler of endometrium looks. So we can divide this endometrium lining into 3 zones. Sorry, it is 4 zones, which is zone 0 and zone 1, 2, 3. So zone 0 is the intervening line between the myometrium and the endometrium. That's supposed to be zone 0. When the blood vessels reach there, we have to give the report as zone 0. And when it reaches exactly the first line of endometrium, that is a hyperechoic starting point of endometrium near the myometrium, that is called as zone 1, and the hypoechoic mid layer is called zone 2, and the cavity itself is called zone 3. So the best part of the blood flow pattern would be definitely zone 2 and zone 3. Even if you have blood supply till the cavity or just above the cavity in the hypoechoic area, that means this pattern or this blood supply is good enough and it gives a good receptivity for your implanting embryo. So this is how we have to go ahead with a blood flow pattern. So there is another technique which we use regularly in Rainbow Hospital, that is sonohysterogram. We do this as a routine for all the patients who are attending a clinic for fertility issues, just to see if the cavity is normal or if they have something to do with the tubes and if the cavity is abnormal or if there is a distension problem. So I'll just explain you quickly how this test is done and when this test is done. So when is it done is exactly on day 7 to day 9 when is this test have to be done. Day 7 to day 9 the patient has to have no bleeding those days. That is the apt day to fix this test. So how do we do is put the patient in a lithotomy position, take either an IUI catheter or a Cook's catheter. Cook's catheter is a catheter which we use for embryo transfer. So these are the two catheters we generally use. So after draping the patient very well, then retract all your vaginal walls, either using a cuscos or using a sim speculum. If you're using a sim speculum, you would be using valcellum to hold the anterior cervical wall. So after using that, put the cannula catheter into the cervix and into the cavity through an ultrasound guidance. So the ultrasound guidance would be definitely through a transvaginal probe and not abdominal probe. So using this guidance, once you are into the cavity, just start pushing normal saline into the cavity. So this is how the picture looks before pushing the normal saline, like where I'm putting my cursor. And then the second picture after distension and after my fluid has gone inside, this is how the picture looks. So the difference is, if at all, this is a normal picture where you have seen the nice wall and it should be smooth enough and the regularity of the endometrium should be maintained. So what interpretation do you do is, when you put a speculum, first thing you observe is whether your cervix is good enough. Is there an erosion? Is there a white discharge? Then once you try putting your catheter, then you know whether the catheterization is easy or difficult or which way it is going. Is it going straight and down? Is it going straight and up? So you know the direction of the canal. And then after putting the catheter inside, once you push the fluid, the things which you have to really check or look into is the distension. First thing is, so in distension, whether the cavity is distending good or whether it is distending moderately or it is not at all distending are the three things which you have to look into. When you look into the endometrium, whether it is regularly lined endometrium, it should look very smooth like this, like how it is shown in the picture. That means it's a very good endometrium. If it's irregular and then something is popping out, that means it might be a irregular endometrium or it might be a polypoidal endometrium. Or if you can see any uterine abnormalities like subseptate uterus, or if you see two cavities, it might be a bicornate uterus or it might be a complete septum. So all these things could be diagnosed in one shot in as an office procedure. So these are the abnormalities which we generally look into in sonography. So the first picture where I'm putting my cursor is where you can see small two polyps which is sitting inside the cavity. This is how a polyp looks when we do a sono. And then the second picture shows a big submucous fibroid which is nicely sitting there. And the third picture, the first picture and the third picture shows before the fluid injection, and the second part of it shows after the fluid injection. So here it is very important to note that the distension is absolutely not that very good in the second picture which we have shown when compared to the normal picture. That means once the distension is not good, then your thought process should be whether there is a synechiae, whether there is an adhesion. And these adhesions and synechiae are generally because of rough DNCs prior or major surgeries which she has undergone, or it might be just because of tuberculosis, or it might be just because of PIDs. So all this should be taken care of. So hysteroscopy is definitely the best tool which you can use when you have some pathology to look into in sono. So once you're done with sono and you find some pathology, or if you're finding some difficulty in doing sono itself, like sometimes we find cervical stenosis. So in such cases, when we have cervical stenosis, we definitely opt for hysteroscopy. We have Dr. Niraj, who is very good in hysteroscopy and laparoscopy at our center. So the patients would be operated by him. So the threshold to use this tool should be definitely less. That means only if you have some pathology, you can actually go ahead and proceed for hysteroscopy, just for a patient benefit, because the cost effect is very less in sono when compared to hysteroscopy. But definitely a recent study says that if you have a pathology which is already diagnosed in sono and you go ahead doing a hysteroscopy and remove the pathology, your pregnancy rates are going to double. This is what consensus 2010 consensus says. So let's quickly move on to the treatment modalities. How do we actually treat all these problems which we already made a list of? Is medicines. So if you have found that a patient is having an endometrial tuberculosis, you have to take a physician opinion and put them on AKT either for 3 months or 6 months depending on the course. And once the AKT kit is completed, you can redo the test of taking an endometrial biopsy and sending it for TB-PCR. Before you start off with your IVF procedures or ART procedures, you have to mandatorily make sure that the TB test is negative after your post-treatment. And then surgical removal. In case you find subseptate uterus or a complete septum, or you find a big polyp or a nice submucous fibroid which is sitting there, I think we have to just remove it before we proceed. And the adjuvants which we generally use for IUI protocols or IVF protocols would be my discussion in the next part. So these adjuvants, in case if you see any decreased, lining and which is not up to the mark in day 9 or day 12, yes, that is a point where you have to add this estrogen tablets or the blood flow increasing tablets or any GCSF and all these things. So the thing which I really wanted to stress is, before your follicle grows, do not start your estrogen tablets or your blood flow tablets, because all this is again going to hamper your follicular growth. So whenever your follicular growth is at around 1.2 and above, only then you have to start treating your thin endometrium, and not from day 2 or day 3. So that's why when we generally put them on estrogen therapy. So in estrogen therapy, we generally take progesterone estrogen pills. It might be estrogen progesterone pill. So first, what do we do is we put estrogen pills. Either we can give them orally or we can give them as a suppository. And then after the ovulation is over, you can continue the estrogen pill for next 14 days along with your progesterone pill till she sees her pregnancy test. This is how we do with an estrogen therapy. For blood flow, we have been using two types of tablets, which is a low dose aspirin, which is just an ecosprin. Either you start off with 75 mg or 150 mg, and then or you can put them on sildenafil. Sildenafil, please do not give them orally. You can give them vaginally, which is 25 mg, either twice daily or once daily. And depending on your scan and the Doppler, you can either increase them or decrease them. But sildenafil, be very careful. In case you get a pregnancy test positive, immediately sildenafil has to be stopped, because the study says they have some teratogenic effect on the baby. And coming on to the next level of modality, so these are just tablets where you can add off immediately for an IUI cycle or a natural cycle. But coming to these modalities, which is GCSF and plasma rich protein in platelets, plasma rich platelet, these specifically we use in an IVF cycle when they have recurrent miscarriages or recurrent implantation failures in previous IVF cycles. So these are the patients we generally use these precautions. So in Rainbow, we use plasma rich platelet as an infusion in thin endometrium who is not at all responding for the normal FET cycle, when we put the whole protocol and still we don't find the response. This is what we use. So what we do is we draw 20 ml blood from the patient. So that is the autologous blood. So once we put it under the centrifuge and turn it for 1200 RMPs, then we get a pellet on top which is rich in platelets, and this pellet is separated and then it is put again into the centrifuge and it is turned again at the rate of 2200 RMPs, and then you get a proper pellet which is very rich in platelet. So this pellet is taken into your Cook's catheter, which this catheter is generally used for your embryo transfer. So take it into this catheter and immediately it has to be inserted into the patient's womb. Where you have to insert is, you have to insert just 1 centimeter above your internal os. That's where you have to inject this platelet rich plasma, and it should be in a very slow manner. It should take almost 15 to 20 minutes of your time by injecting this. This is how we generally do it for an IVF case. So what else can we do in an IVF case is definitely you can think about FET, which is frozen embryo transfer. If somebody has a thin endometrium in the whole cycle, let's say when you're doing an IVF cycle, you're planning for a fresh transfer, but the mid-cycle endometrium growth is not that very good, and it is like somewhere around less than 8 mm. Let's say your trigger day endometrium is somewhere less than 8 mm. I think you have to take a call on frozen embryo transfer. Freeze all the embryos, explain the patient, and then give a month's break, and then once she gets a natural cycle, plan for an FET. That would be a perfect thing. If at all there is a patient who has been having a troubleshoot even after developing an good type of endometrium with all these adjuvants, and then you have already planned for FET, but still you have a troubleshoot in getting her pregnant, and so many times there is an implantation failure. Probably you can opt for this endometrial array. Endometrial array is a molecular diagnostic test wherein you can exactly locate the window of implantation in a patient. So you can do a personalized embryo transfer in these patients depending on the exact window you get. So this is how an endometrial array is done. So the newer trends is the coming up trend in thin endometrium is definitely stem cell therapy, which everybody is looking forward for. So in stem cell therapy, as everybody knows, that stem cell is a totipotent cell where it can regenerate into whatever organ you want to replicate as. So we can as well use it for endometrial replication in a very bad case wherein it is even the basal layer is affected, and there is a lot of thin endometrium because of tuberculosis. Tuberculosis, I think, is the only place wherein we have a very bad hit to the endometrium where it doesn't recover because of fibrosis. So probably this stem cell therapy, if we could try and we could make some benefit out of it, would be definitely a good option for those patients wherein we don't have an answer with anything else with whatever above I have discussed. So this is a new trend we are looking forward for. So let's talk a little about evidence and facts. So what does the evidence say? In an IUI cycle, if the thickness of the endometrium is less than 6 mm, and if it is more than 14 mm, then definitely the pregnancy rates are going to be very low when this is to be checked on the day of egg release. So the implantation, pregnancy, and the live birth rates are definitely going to be low even in an IVF cycle if the mid follicular endometrium is thin. So do not take that cycle and plan for an FET. Studies have shown that mid-cycle endometrial thickness less than 8 mm was definitely associated with poor IVF outcomes. So at least 9 mm and above should be an opt endometrium to go ahead with the fresh transfer or an IUI cycle to just continue without giving any adjuvant. So let's continue with the facts. According to the evidence for whatever adjuvants I have spoken, so there are a lot of controversy on aromatase inhibitors. Prior it was banned, and now again I think we have all started to use aromatase inhibitors for ovulation induction. So I actually spoke about causes of thin endometrium. When I spoke about the causes, I told that drugs of fertility can also cause thin endometrium. So Clomid is one of the drugs which can actually have an anti-estrogenic effect on the endometrium. That too, when you do a cumulative cycles, when you do 3 cycles to get continuously at a shot, then it has a larger impact on the 3rd cycle on the endometrium. So this is where you cannot give in Clomid treated cycles. We cannot actually put these adjuvants like oral estrogens cannot be given. So in these situations, the best option would be aromatase inhibitors, which is Letrose, which is a very good drug, and it has been proven for a good pregnancy rate as well nowadays. So that would be the best option now. And what does low dose aspirin has to say and sildenafil has to say? So all the trials and the articles whichever has been done on this to improve the blood supply is still not enough to say that they definitely improve the blood supply. There are few RCTs which say they might improve, a few RCTs they say that it doesn't improve. So there's still a controversy to use these drugs. It is up to the clinical practitioner whether to take a call on these drugs. And L-arginine also to be known to increase the blood flow by vasodilatation as a mechanism of action. So this also has not shown any evidence to increase the endometrium receptivity according to the studies. So GnRH analogs, generally the GnRH analogs are supposed to be given one cycle prior, that is the prior luteal phase. That's how we give in thin endometrium cases or endometrial hyperplasia cases. So this is all, we really don't have facts, or we don't have proper RCTs or multicentric trials which say that they actually act. So this is all again practitioner based, whether you wanted to try it or not. GCSF infusion, although the case series and non-randomized studies are encouraging, there's only one RCT which has been published, and that actually it has failed to show its impact. But definitely in routine practice, we have seen an impact of GCSF in increase of endometrium and implantation rate. So these are the references for whatever evidences I have shown. So definitely the take home message: select a best seed, prepare the best soil, plant at an appropriate time. This is very, very important. Taking a different approach achieves a pregnancy many times in
Hello. Yeah, am I audible, Pallavi?
Yes, yes, sir.
Yeah. Are you taking questions?
Yes, sir. Yes, sir. We are ready to take questions.
Yeah. If you go in your question section, we have the
Yes,
question.
yes, sir. I'm just opening it. Yeah.
Yeah. So there is a question from Dr. Mansa Manu, who's asking what is the dose of estrogen. Can you see that?
Yes, yes, Dr. Mansa. What is the dose of estrogen is what the question you asked me. So the dose would be depending on the endometrial lining and the day of endometrial assessment. If it, in case you have something like 4.5 or 5 endometrium on day 9, definitely I would start with TID dose of 2 mg estrogen orally. And in case if it is even more bad, let's say on 12th day also, if I have something around 5 or 4, then I would definitely put 2 tablets TID. So maximum dose which you can give is 2 tablets TID for estrogen therapy. Sometimes you can actually use these estrogen tablets even as a suppository if it's not working orally, because sometimes the local action is really good in some patients.
There's another question. Is the SIS ecogenic contrast? Can you see the question? Can you read it?
Yes, sir. Yes, sir. Dr. Nandini has asked us a question saying that in the SIS, ecogenic contrast agents such as air bubbles may be used, especially when evaluating for patency of the fallopian tube. Can you please explain on this? It's in CAN's ultrasonography. Just as a doubt, just to clear. Yes, madam, we have actually not been using anything of this sort. We're just using normal saline. And to see the tubal patency, we cannot actually say that both the tubes are normal through, sono histogram. We can say that, okay, if you push some 20 ml and then see a 20 ml fluid in the POD, then probably indirectly you can correlate and say that, okay, both tubes are normal. But definitely, like an HSG, you cannot say, okay, right tube is normal and left tube is normal. That cannot be done. And we are not actually using this kind of procedure. So probably I have also have to go and look into this. Thank you so much for this post so that I also can go and look into this. So Dr. Nagesh Ravani has asked us, can aspirin be after confinement? If so, then how many months? Yes, madam. Aspirin can be continued after the conception as well. Till your NT scan, I would definitely continue if it's an IVF case. And after an NT scan, if the uterine artery Doppler says that there is no, preeclampsia, presumption for the pregnancy further, then I can stop it there. Or if they say there is some Doppler changes that this patient might land up in preeclampsia, or there is a prediction of preeclampsia, I would definitely like to continue ecosprin up to 32 weeks of pregnancy. or even up to 36 weeks of pregnancy, madam. So Dr. Avanti has asked us for estradiol valrate, is it too effective with food or before food or after food? Yeah, generally the estrogens are supposed to be taken post lunch or dinner. That's the better time where it works. Dr. Priyanka Lakshmi has asked us, which day do you start estrogen and progesterone therapy? Elaborate. So as I said, the progesterone therapy in an IVF case or in an IUI case would definitely be after a release of an egg, not prior to that. But estrogen therapy, it depends on your endometrial lining and the day of your scan. So depending on that and your follicular size, all three you have to take into consideration before you start an estrogen. What is your experience with stem cell therapy in thin endometrium? Dr. Shashank Singh. Sir, actually we have, frankly speaking, we have not tried stem cell therapy in our clinic at all till now. But I have few people from Chennai, so they have actually tried stem cell therapy and they say that the things are working out well for tuberculosis patients. Sri Ram in Chennai is actually doing the same. So probably if you have any doubt, we can, try a contact from them and get an answer from them. Dr. Shalini Singh have asked us which estrogen we can give vaginally. In what dose? What is your What if your follicle grows by the day of 25, and if your endometrium on that day is 10 mm? Can that cycle continue? Yes, in case of polycystic ovaries, wherein you expect some people to grow the follicle by, day 21. So day 25, 21, 10 mm, I think it's good enough in case if it's a polycystic ovarian patient. Yes, you can still continue the cycle, give her a trigger and then release an egg and ask them to, try for a pregnancy. We in our clinic actually have achieved a lot of pregnancies like that after 21st day also. So Dr. Vanaja has asked us, sildenafil to be used from which day? The appearance of cumulus oophorus on induction, is it a good sign or do we have to terminate? Yeah. So sildenafil has to be used depending on your endometrial lining. Actually, frankly speaking, the sildenafil also has an effect. If you use too much of sildenafil, it can also has an anti-estrogenic effect and thinnen the endometrium. So be very cautious when you're using sildenafil vaginally. Make sure that your endometrial lining is triple line, and then you have, a good look of pattern like type B endometrium, and then at least the thickness should be 9 mm when you're trying to put a sildenafil. So sildenafil generally the thing is to improve your blood supply. Probably it might not increase the thickness of the endometrium, and don't push too much of sildenafil so that the thickness actually falls down if you use too much of sildenafil vaginally. So Dr. Shalini Singh again has posted us a question: which estrogen is given vaginally? How to approach a case of unicornate uterus? So the estrogen vaginally, you can actually use the normal estrogen valerate. The tablets which we get in the market can be put vaginally, like Estrobag and Eva Active are the brands which we generally use. I don't want to mention the brands, but estrogen valerate is which the tablet you can as well use vaginally. And how to approach a case with unicornate uterus, Dr. Sushma Reddy has asked us. So in a case of unicornate uterus, you just have to check the tubes and the ovaries. In case sometimes the unicornate uterus, even if it's a half part of the uterus, the uterine bulk is good enough, and then you can see a nice triple line endometrium. Probably in these patients, if you have one tube open and the same side, if the egg is growing, then probably you can, try an IUI cycle in them. In case if the tube is closed and then the opposite side, the ovaries are too far, then probably you can try an IVF. We have actually a couple of cases wherein we had a unicornate uterus with the one side tube open and then the same side ovarian follicle growing, and they had made pregnancies with IUI as well. And thank you so much. Now Dr. Niraj would be taking over for next session, please. Thank you.
Right, thank you, Pallavi. Right. So good evening, everyone, and thank you for taking time out and being with us here today. I'm not sure if I'm able to share my slides. One sec. Screen కనపడుతుందని చెప్పి కనపడుతుందా? Right. Okay. Okay, so I'm going to talk on fertility enhancing surgeries, the current role. Now, this is actually a very big topic and can speak for hours on this, but it probably may not be possible to really cover all of it in one go. But I'll try my best to cover as much as possible in the allotted 25-30 minutes. Now, when you talk of infertility, we all know that it can be at any level from vagina up to the pelvic internal organs where things could have gone wrong. You have to identify what the problem is and then take it from there to address it. Now, endoscopy, when I say it, is obviously hysteroscopy and laparoscopy both together. This list is not really a complete list. There can be many more things which you can add. Randomly, I have put many conditions here which in which endoscopy does have a significant role in improving fertility of a particular woman. Now let's start from vagina and the uterine septum. Now these are all these videos which I'm showing you are the ones who were referred with infertility. For this talk especially, I have made this videos, and all of them, but for one or two women who I'll tell, did not get pregnant, but almost all of them did get pregnant following following these surgeries which we did. Now this is a complete vaginal septum. As you could see, it was extending right from the introitus up to the fundus. Now initially I attempted doing the septal excision with scissors. That was more for demonstration purposes, but with this kind of thick septum extending from the introitus up to the fundus, it's better doing it with your receptoscope or any other device which you prefer using. And once this receptoscope, once the septum is resected, always make sure that you do dye test to see if the tubes are open, because if there is any problem there, you can address it at the same time. When you look at uterine causes, broad ligament fibroid, here you can see I've done surface marking of the broad ligament. This was just on the operating table. Now this clearly causes a whole anatomical distortion. You can see that the uterus is completely plastered onto the right pelvic wall, and there's a huge broad ligament fibroid. This lady is not going to conceive naturally, and even if she conceives, it's going to be a big challenge during the pregnancy. So she was actually referred by one of our infertility consultants who sent her with a diagnosis of broad ligament fibroid. Here, doing laparoscopic surgery, one of the things you have to keep in mind is the ureter, which is on which this fibroid is compressing. That's the main structure. On the side, there will be pelvic side wall vessels, which you have to be careful about. In fact, these fibroids, I feel, are far more easy to remove surgically as compared to the myometrial fibroids, simply because this is not embedded in the myometrium and these come out very easily. The only thing is you have to deal with the feeding vessels, as you are seeing here, and these will be quite at the base. So you have to go deep down at the base and take those vessels before you enucleate the fibroids. Once the fibroid is enucleated, then depending on how you feel that area is, you could suture it, or you could probably get away without suturing, but it is something which you have to do based on your experience. Now here you can see that there's a huge dead space there, and the ureter will be there, major pelvic sidewall vessels will be there. Make sure all the time that your ureter is in fact not injured by looking at the peristalsis. And here we did have to keep some hemostatic material to control the bleeding, and on top of that we did suture. Now this fibroid was quite huge. As you can see, it was almost 12 by 14 centimeters, and we did remove it by morcellation. This lady did get pregnant after a few months of the surgery. I think it was 8 or 9 months of surgery that she did get pregnant. Now these are the fibroids, which are huge, and they do cause significant anatomical distortion. By no way you can expect that this lady is going to get pregnant. I mean, she had significant pelvic pain as well, and she had significant dysmenorrhea, and the anatomical distortion, no wonder, was causing infertility. Now removing these may look easy, but it is not really easy, and more importantly, suturing them is not really easy, because it's a very awkward angle. You have to go deep down in the pouch of Douglas and put your laparoscopic sutures. That's where I think your suturing skills will really be tested. Now here, because there was a significant suture line behind, I had to keep an adhesiolytic barrier, which is interseed, which we use to prevent adhesions of the bowel, especially rectum, to the suture line. Now, the second important area in infertility is tubal pathology, those with tubal pathology, which could either be infectious pathology, non-infectious, or anatomical distortion. Again, this list is not exhaustive. There will be things which you can add on to these things. Infectious etiology can be chlamydia and Neisseria. Now, chlamydia is far less diagnosed, I've seen, in India than it is in, for example, in UK. In UK, it is diagnosed far more often than we diagnose here. But it is a significant factor in tubal infertility. Tuberculosis here is, as we all know, more common. Then there are those non-infectious causes and anatomical distortions. I'll show you a few examples of these as to how we deal with them and how good we can get the results. Proximal tubal obstruction is very common here, and I have done a lot of them. And fortunately, we have a success rate of almost 80 to 90%. Almost 8 to 9 out of 10 women who we have done proximal tubal cannulation have actually gone on to get pregnant. Now, here you can see that bilaterally at the cornu exactly, there is this polyp. It is like a curtain. You drop the pressure, and you can see that the tubal ostia is completely obscured and occluded. Theoretically, one may argue that the sperm can still get around that area, but I think it is a very clear mechanical blockage. And interestingly, it is on both the cornu. And the very fact that these were responsible is proven in the hindsight, because after we removed these, the woman did get pregnant almost in the next second cycle. So it was a significant mechanical blockage at the level of tubal ostia, which all it needed was removing it and making sure that the tubes were open, and she got pregnant. So these are the situations where you cannot remove these without a hysteroscopy guided procedure. It cannot be removed and diagnosed as beautifully as you can see here. And once you have done this, always again, if you have a scope inside, obviously for any other reason, or you have put it down for a diagnostic laparoscopy, you're going to do a tubal patency test as well, because this is an opportunity to even address proximal tubal block if there is one. Now, this is tubal cannulation. As you can see, that you have to align it with the tubal ostia, and once you have inserted your tubal cannula into the proximal end of the tube, then you flush it with your normal saline or with the dye, and you can see that this dye is beautifully going in. And even if there is something like anatomical mucoid debris in the tube, that is going to flush out, and the tube, you can see, is opened up. These are the ones which will give you a great success rate. And as I said earlier, we have a success rate of 80 to 90% in tubal block, especially proximal tubal block. Distal tubal block is a different ball game, which is not easy. Distal tubal block is not a kind of very gratifying procedure in terms of obtaining results. And here, as you can see, there's a distal tubal block on the right side tube. This lady actually had an ovarian cyst, which was diagnosed almost for 18 months before she presented to me, or before she was referred to me with an acute abdomen. And you can see that that cyst had undergone torsion. It was looking necrosed, and she was initially visiting the referring consultant with infertility when they picked up ovarian cyst, but were managing expectantly. In the discretion of that consultant, that was the right decision to do. But anyway, eventually, unfortunately, she had torsion of the ovary, and that also torted her tube, and that you can see led to the hydrosalpinx. Now you have to see how densely it gets adhered once it torts, or even we don't know whether it was even adherent even before, but it couldn't be, because if it was adherent, it wouldn't tort. You can see the twisted pedicle there. All you have to do is untort it and leave it. We did not remove the ovary. Again, this discussion, I think, has gone on for a very long time, and all of us have got message that you don't have to remove the ovary, especially in young women in torsion ovary. You can just untort it, leave it. You can see the color almost coming back, and then you can conserve the ovary, and that will only make her fertility status better. Now here you can see on the left side, more importantly, not the right, which I'm dealing with, left side is completely gone. That tube is hydrosalpinx. That is no way going to be healthy and be productive in terms of achieving fertility. And this hydrosalpinx, most infertility consultants, I think, also are in the audience, as I can see. And that fluid does cause endotoxicity. It does cause alterations in endometrial receptivity, and mechanically it may flush the embryo as well. Now, these are the tubes which you would rather disconnect. Disconnection of tube is what most infertility consultants send me patients for, and either it is disconnection or removing. You can see the right-sided trumpet tube. That tube is completely gone. It's better off. There is no way you can salvage that tube, and even on the left side the tube is gone, and this lady has multiple fibroids. So there are multiple things which need addressing here. From infertility point of view, I don't think those seedling fibroids are contributing anyway, but this tube, as you can see, is completely non-functional. So you have to do a contained removal of the contents of this tube, because if it is pus, you're going to make it worse by if there is significant spillage in the peritoneal cavity. Even if there is spillage, for example, try and keep it absolutely minimal. Do not give a thorough lavage initially, because it's only going to spread it into the upper abdomen. So if there is spillage, just suck it out. Don't use irrigation, because irrigation is going to spread that peritoneal material even more. So here the tube on both the sides is gone, and the consensus was we do fibroid removal, which I did. Those small fibroids even which were seen, and we did disconnect the tube and sent her back to the infertility consultant. This is one lady who I did not have feedback for, because she was from outstation consultant and never got in touch with her. Now, when you look at adnexal pathology, there can be numerous different conditions which we can see here. This is a lady who had had laparotomy in the past and had, as you can see, thick omental adhesions. I mean, these are adhesions which can, the moment you start doing this, you can imagine that even her pelvis is going to be quite bad. Again, depending on infective etiology. If it is surgical, it may not be as bad. You might just remove the surgical adhesions and go. But if it is infective pathology, then you will have significant adhesions even in the pelvis. I think I have a few slides following. Now you can see that this is a paratubal huge cyst on the left side, and that is the ovarian cyst. So although she was sent with an ovarian cyst that is impacted in the pouch of Douglas, that's quite huge, almost 8-10 centimeters. But there is paratubal cyst which was completely missed on transvaginal scan. So you have to be prepared when you do laparoscopic surgery. Don't expect that what this scan findings show is what you're going to see. There are many surprises and numerous things which we have seen which were completely unanticipated. And therefore, you have to have the right skills to do these procedures. Or if you don't have the right skills, you at least need to have some backup, where if you come across unexpected findings, you can then call for help. Because unless you do the surgery complete, it's not going to give you the desired results, and you don't want women coming back with recurrence. I mean, there will be situations when recurrence will happen, but there is something which is persistence of disease. That is not what you want, because you want to do the complete job at one go as much as possible. Yes, but if there is something like stage 4 endometriosis which you see and you're not able to do it, those procedures can be done at a referral center as tertiary, as secondary procedure, or a 2-stage procedure. Here again, you can see that this is the tube on the left side. This is completely gone. This is beaded appearance. It was solid, and we just removed the tube. And the consultant who had referred has actually deciding Dr. Pallavi had referred. In fact, most of these women, Dr. Pallavi or our in-house consultants had referred. There are outstation referrals as well. And once you disconnect it, most IVF consultants, that is what they would want. I mean, but my advice always is to try and remove the tube. Don't only disconnect, because once you disconnect and leave that tube there, it's going to cause further swelling, and at some point it might cause dragging pain in the lower abdomen, and you don't want women having another surgery again. Now this is peri-ovarian adhesions. You can see this is infective etiology of adhesions. Now this, what happens is when you have this kind of adhesions, you can see that the ovary actually is completely encapsulated in the filmy adhesions. So theoretically, one can imagine that even if she is ovulating properly, that ovum is not going to be picked up by the fimbria, because the ovary is completely encased in the adhesions, and it is plastered to the pelvic side wall. So free these adhesions, and that's all it is needed. I mean, these women do get pregnant. It's only a small anatomical correction that is needed. Now, this is infectious etiology, we all know, because she did not have any surgery in the past, and these filmy adhesions are almost always suggestive of infective etiology. Now, this also, that she had some hormonal elements which was indicating towards polycystic ovaries. Therefore, the consultant had requested me to drill the ovaries, which we did, laparoscopic ovarian drilling. Again, this lady got pregnant in subsequent cycles. She also had tubal block, because for which we had done tubal cannulation, and again the outcome was very good. Now, when you have adnexal pathology, I have seen numerous women who are being managed conservatively. I'm not saying there is no role for conservative management, but beyond a particular size, please refer them for surgical, or you do surgical treatment, because these are the women who are never going to respond to medical treatment. I mean, these are huge cysts. This lady also had presented with acute abdomen because she was being managed with some contraceptive pills by outside somewhere, and she presented with acute abdomen. It was a really serious cyst, and also had hemorrhagic components. It was a multi-lobe cyst, and one of the reports came out as hemorrhagic cyst, and the other one came out as simple serous cyst. But this ovary at the end of the surgery may still look bulky, and she had a huge raw area which was bleeding, and I could not have left it like that. So this is for demonstration purposes again. You can always do ovarian resuturing, and although it looks quite inflamed and swollen at this stage, it almost always subsides in the following few days. All she needs is some anti-inflammatories, and it subsides. And this ovary, when you look back maybe 2 or 3 months down the line for a follow-up scan, you will not even be able to differentiate or imagine that this ovary was this big at the end of the surgery. It is all because of inflammation and overswitching. So these ovaries went back to normal, and she did get pregnant eventually. Now, pelvic infection is something that this is a very typical medical school knowledge, which is Fitzhugh-Curtis syndrome, typical of chlamydial infection. Now, this lady had a complete curtain in her upper abdomen and the lower abdomen, so I could not visualize any pelvic organs at all. As you can see, there was a whole thick omental curtain which was extending from lower abdominal wall right into the bowels. So you have to first get rid of those adhesions to even see or visualize the uterus and the tubes. Now here, it was very typical that we had chlamydia, which was there based on the findings on the uterus, on the liver. And here I did take omental biopsy. Nothing much could be done because it was all looking plastered and very friable, and there was significant risk of injury. It was infertility. Therefore, and she surprisingly did not have any symptoms at all. So there was no point doing adhesive lysis just because you see them. Now, the adhesive lysis which I did was to have access to the lower genital organs, sorry, to the internal genital organs. Otherwise, in pelvis, adhesions were not going to help and get her pregnant. So I took the sample from momentum for PCR, tuberculosis PCR, and it did come out positive. Now here you can see this was all abdomen and pelvis was full of pus. Now these are the women who would give up hopes, who should give up hopes of getting pregnant naturally, because it has completely damaged the endosalpinx, the exosalpinx, and the whole anatomy in the lower abdomen. The pus here I am showing is gone in subdiaphragmatic space as well. That is the liver, and the pus was even on top of the liver. And there was liters and liters of pus which I took out from there. Now, this is interesting because this lady had actually surgery within 6 months of a previous surgery. This lady was referred to me having had PCO drilling somewhere outside just 6 months back. But for some reason, the consultant, infertility consultant, who was very keen that I do a laparoscopy because she wasn't happy with the scan findings, and she was saying that the ovaries were completely adherent. So can you please have a look again? Although reluctant, I did a surgery, and I'm happy that I did surgery on her. As you can see, this is simply PCO drilling, which can lead to that kind of adhesions. Looking at the pictures which were given at the time of index surgery by the other consultant, I think they were absolutely fine, and she did a very good job in doing PCO drilling in this lady. It was absolutely not surgeon's fault at all. The reason I'm showing you here is for two reasons. One, the confidence of that infertility consultant who told me that she has adhesions, you have to remove it, and she said she's very confident that it needs drilling surgically, and she does not want to go ahead with any infertility procedure. This was, in fact, I think Pallavi again who had sent me this patient. So these were the findings. And one learning lesson here also is that don't take PCO drilling also as a very simple procedure and just do randomly, because it can, once you take out your trocars, you don't know what's happening inside, and it can lead to adhesions like this. If the ovaries are adherent from both the sides, you can see these filmy adhesions between the bowel and the lateral pelvic side wall. So these are the ones which you cannot take it lightly. And this lady absolutely got pregnant in the following. In fact, she's in States now, and she sent me picture of her baby, who's now I think 1 year old, and she is absolutely delighted that she got pregnant. Although it needed a lot of counseling for her to have a second procedure within 6 months. But you can see here, even the bowel is stuck. And all she had, when you look back at the previous surgery pictures which the other consultant had done, it was not like this. Those were very clear pictures. But this is the what shall I say, sequelae or the morbidity we have even after laparoscopic surgery, the adhesions. So I had to remove all these bowel adhesions. Sigmoid is clearly adherent there. And it was, I mean, I did not prepare her bowel at all because I was not expecting that it will be this bad, but it all went well, and there were no problems at all. Now, when you look at this is again a very popular lady from Hyderabad. She was referred again with infertility, and she had these adenomyotic spots on the uterus. The left side ovary had endometrioma. You can see that it is all stuck to the pelvic side wall and had small endometrioma. But all infertility consultants and gynecological general gynecologists also will know that even that much is enough to cause infertility. Endometriosis, even if it is superficial endometriosis, can cause significant infertility. And this lady again had uh, um, those adenomyotic spots removed. In fact, there was a debate going on whether I should really go on and remove uh, um, uh, these little adhesions or and adenomyotic spots or not. But eventually, she got pregnant and she has a baby who's also, I think, 1 or 2 years old now, and that's all absolutely fine. So endometriosis, again, it is in itself a big topic which we can talk for hours about how to manage endometriosis. But as far as possible, do endometriotic cystectomy. There will always be a debate between IVF consultants, because there is enough evidence to show that when you strip the endometriotic cyst, you will remove some normal ovarian tissue as well, and that will lead to loss of follicles. I completely agree with that, and therefore, from IVF perspective, infertility consultant perspective, that is a very valid argument. But from a surgeon's perspective, from a laparoscopy, from a complete removal of the cyst is concerned, I think cystectomy is the best to reduce the risk of recurrence or even persistence of the disease. And even the outcomes, there are a good number of studies which have shown that cystectomy does increase the pregnancy rate, although it definitely reduces the number of follicles because of removal of healthy ovarian tissue. Those little adenomyotic spots really took not more than some 15 or 20 minutes from removing to suturing, but that definitely should be done because they will eventually cause us symptoms, or if it goes deep down inside, then that's going to cause problem to her from a symptoms point of view also, and from a infertility perspective as well. So overall, to conclude, the natural inclination of a gynecologic surgeon like me is to intervene in the setting of visible pathology. So, but it does not mean every pathology you see you must go and address it straight away. You have to think whether it's going to help you from the reason she's been sent to you, or the reason you're seeing her. Is it infertility? Is it symptoms? And whether your surgery is really going to address that particular issue. Don't do a surgery just because, or don't do a adhesiolysis, for example, just because you have seen an adhesion. It may not be causing her any problem. Leave it alone. But if you think it's going to address her concern, then please go ahead and do it. Tubal occlusion is one of the best things. I think you must go for tubal cannulation. Again, ART, I don't want to venture in that area, but I think from my experience of a success rate of 80 to 90% in proximal tubal occlusion, I would always recommend doing the hysteroscopic tubal cannulation. Therefore, the true challenge in treating infertile couple in the age of ART is to understand whether surgical intervention is beneficial or an unnecessary delay to achieving pregnancy. So I think I'll just end my talk here, and we're happy to take questions. There are a few more slides and videos, but I think I'll just stop here. Now, if you can imagine one tree which can bear all the fruits, that doesn't exist, but in practice there is an instrument or a device which can address all the issues in infertility, or most of the issues in infertility. Either you use laparoscopy or hysteroscopy, and as I've shown you, there are numerous conditions in infertility which can be addressed with infertility. And just to come back to the topic of today, fertility enhancing surgeries, as you could see, there are so many conditions which we can enhance the fertility of the woman by doing these surgeries. Thank you very much, and I'm happy to take any questions you may have.
Hello, sir.
Yes, Pallavi.
Yes, sir. There's Dr. Revati, who was asked for chances of adhesion after surgery in your experience.
Chances of adhesions after surgery. Now,
Yes,
it
sir.
is a vague question, very important question, but a very vague question. I'll tell you what I mean. It depends on what surgery you have done. If I have done something like a massive fibroid which I have removed and she has a big scar on her uterus, then the chances of adhesions are more as compared to doing something like a small, I should not say small because I've just shown you how PCO drilling also can end up. So it's not, it depends upon the procedure which you have done. For example, if it is anterior fibroid you have removed, then chances of adhesions are very, very minimal because it's very unlikely that bowel will go and stick to the anterior surface of the uterus. But if it's posterior, it's definitely going to adhere. So it depends upon the procedure you have done and the measures you have taken to reduce the adhesions. Those microscope surgery principles still remain true for laparoscopic surgery, including good saline lavage, making sure your hemostasis is very good, making sure your suturing is very meticulous. All those things do contribute towards your significant risk of adhesions or no adhesions. Anything else? Yeah, do you
There's one more question from Dr. Shashank.
No, I can see that Dr. Sashant Singh has asked, do you insert a copper T or a Foley bulb post-septal resection? No, I don't insert any Foley bulb or a copper T because copper T really is not going to help because it won't oppose it's not big enough to oppose the surfaces. But I do give estrogen, yes, for 2 months, and then that is good enough. We've never had any problem giving estrogen, and then they come back for follow-up and I never thought that I should have put a Foley or a copper T. Then I think there's do you perform unification metroplasty in biconic uterus? No, I haven't done unification because I have never been referred. I have never seen a biconic uterus where I thought clinically it was indicated to do. Even if it was a small non-functioning horn. We just left it alone and not done it. Chances of adhesions, any enhancing surgery for PCOD with thick capsule. Enhancing surgery for PCOD with thick capsule. I think I get your question. Most PCO will have a thick capsule, so we know, and these are the ones who we do laparoscopy for. Those are the ones who have failed to respond to ovulation induction agents or medical treatment. So we do this polycystic ovarian drilling. Again, nowadays, infertility consultants, if I'm getting some referred patient, then the consultant specifically requests not to use electrosurgery or monopolar diathermy, which we use, because especially in those who have low AMH to begin with, or low follicular count. Therefore, I don't do in those, but by choice, I would do it and use standard those typical 4 punctures, 40 for 4 seconds each. Chances of adhesions after your surgery, yeah, that I have already answered. Do you perform? This is done. With 6 cycles, Dr. Ravli has asked whether with 6 cycles of failed ovulation induction and both couple reports normal, HSG normal, before going to IUI, do you suggest doing a diagnostic lab plus hysteroscopy or go ahead with IUI? If HSG is normal and 6 failed OI, yeah. If it is 6 failed ovulation induction, then I think yes, I would go ahead with the diagnostic laparoscopy. More importantly, hysteroscopy. But again, this will depend upon other parameters, including the male factor. Great presentation. Oh, thank you. Sorry, I was just reading the thing. Okay. Thank you. Yeah. Any? Yes, Dr. Pallavi.
Yes, sir. Yes, sir.
Yeah. Were you saying something?
Yeah, I just wanted to answer this question. With 6 cycles of failed OI and both couples reports being normal and HSG being normal, I think we have not done an IUI yet. That's what this question says. So I think it would be nice to do at least 2 cycles of IUI, and then somebody doesn't conceive, then take a call on laparoscopy, sir.
Yeah, I agree. Yeah.
Yes.
Thank you, Dr. Sunil, Dr. Sunil Jaiman, my friend. Yeah, I think I should thank all of you who've been here and gave your time. So thank you. I think we'll wind up. I hope I don't see any more questions. Sorry, is there any role for ovarian PRP injection in poor ovarian reserve? Pallavi, do you want to take that?
Is there any role of ovarian PRP injection in poor ovarian reserve? Not really. As all of us know that ovarian reserve once going down, definitely it's going to go down. So whatever we do, that ovarian reserve is not going to come back, because everybody knows that your AFCs and the eggs are made once the the mother is in her mother's womb. So that cannot be done once the regression starts. Probably we can limit the rate of regression instead of doing all this and wasting our time and taking her for an IVF, and making use of that time would be an ideal procedure.
Wedge resection were done before. It is not done nowadays. It is not done nowadays because there is enough evidence to say that you don't have to remove a whole chunk of ovary, because you're going to lose a lot of ovarian follicles and you diminish the ovarian reserve by doing wedge resection. The same thing can be achieved by doing laparoscopic ovarian drilling. Therefore, wedge resection, as Dr. Revati has rightly said, it has been given up for many years now. In fact, more than a decade or 2 decades, that wedge resection has been stopped. Wedge resection, in fact, I have only read in textbooks somewhere. It's not even mentioned these days in any modern literature. Then, sir, do you remove asymptomatic seedling fibroids which were discovered coincidentally on diagnostic laparoscopy? Now, if it is really seedling fibroid, yes, I would remove it purely because they will eventually grow at some point. It doesn't take me more than 10 minutes to remove a seedling fibroid, or even less than that. If it needs suturing, maybe another 5 or 10 minutes, because you're saying seedling, it will be one stitch job maybe. It is only from a future point of view that you don't want that lady coming back again in a year or 2 years time with that increased fibroid. So yes, I do remove it, and I would advise you remove it, because those are seedlings today, they're going to be big tomorrow. Dr. Niraj, excellent presentation. Thank you, Dr. Ashok Kumar. Dr. Sushma Reddy has asked, is drilling done on antral follicles? Now, it's difficult to identify antral follicles as such when you're doing laparoscopy. Laparoscopy, when you're typically doing it on polycystic ovaries, now my firm belief is that polycystic ovary in India is far more overdiagnosed than it actually exists. And especially if it is done by radiologist colleagues of ours than gynecologists. Those gynecologists who are scanning themselves, they can put that in context with the history and in context with the hormone studies, and then come to a conclusion. But our radiologist colleagues, I'm not demeaning them. I'm just saying that benefit of correlation between hormone studies and history they don't have it. Therefore, they overdiagnose it. So, to answer, when I'm doing the scan myself and I'm doing laparoscopy myself, I know definitely this lady has polycystic ovaries. So I would go ahead and do the drilling at 4 appropriate but distal places. Again, try and avoid doing it more close to the lateral pole of the ovary, because that is where the blood supply of the ovary comes from. That is where the IP ligament is connected. And by doing that, you're going to compromise on the ovarian blood supply. This is not seen in many books, or many people will not talk about it, but that's a very big point you should have. When you're drilling it, drill away from the IP ligament, not towards the lower lateral pole of the ovary, because you compromise the blood supply to the ovary. So try and do it away. But answering done on antral follicles, it is difficult to say whether it's antral follicles. Sir, is there any criteria for number of drills or punctures in PCOV? Yes, there is criteria. This was published first time in the Obstetrician and Gynecologist Journal, which was in 2002, which is published from the RCOG. And there they had done, this was I think from Bristol or somewhere, and they had done a study where they had randomized people and come up with this with 3 norms. 40 watts setting of your machine for the cautery, 4 seconds, and it should be 4 punctures on each ovary, no more than 4 punctures. People who are trained in the before this paper was published, you may remember that there was lots of holes people used to make, like golf ball appearances, what people used to say, where you just puncture and puncture it. Wherever you see a little bob, you puncture it. But by doing that, you destroy a lot of follicles. So please don't do that. Give no more than 4 punctures, 4 seconds each at 40 watt setting. So that is the criteria to answer your question, Dr. Shashank. Then Dr. Sushma Reddy said, do you limit it to 4 even in CVPCOD? Yes, you should limit it to 4 even in CVPCOD, because the purpose of using monocautery is to bring the hormone milieu in the ovary back, which doesn't depend upon the severity of PCO, but it depends upon the time you apply the electric current for and the number of places you apply for. That is what that study was about, and therefore 4 is enough. Again, when you're doing, say, for example, if you've done 6 or 7 punctures, one may say, what is the big harm I'm doing? The point is you're killing more normal follicles. Second, that video which I showed you about post-PCO drilling ovarian adhesions, you're going to contribute towards that. You and I will never know because we are not going to put the scope back again. This is the first time that I had put that scope again in 6 months' time after the previous surgery, and I've shown you what I show on the video. So no man, I don't know how many PCO drillings have been done by everyone, all of us, and how many of them actually had the adhesions which I showed you. So therefore, please don't do more than 4. If you feel tempted doing more than 4, you can do them, but don't use electrocautery at least, because by using the cautery, you're destroying follicles. By not using cautery, you may not destroy the follicles. So yes, there will be situations where you feel 4 may not be enough. Go ahead and do it, but don't use electrocautery. Yes, Dr. Sushma, yeah. Dr. Shashank, is the puncture to be done in stromal area or follicular area? You can do it in, generally these cortex will be thin, there will be thick, shiny cortex where you feel there is a little more bulge and you feel the fluid is more going to come out, you push it in there. So there is no right or wrong place. As I said, one important thing you remember is don't drill closer to the IP ligament. That is one thing, and don't do many drills in the same area, because if you're doing it more close to each other, you're not really damaging the stroma as much as you want. You would rather be far away at some distance and away from the lateral wall of the uterus, of the ovary. Anything? Any more questions? Yeah. Nothing. I think we'll wind up. Pallavi, are you there? Dr. Pallavi, you also disappeared.
Yes, sir.
Oh, okay. Okay. I think there are no more questions.
Yes, sir. Can
Yeah.
we just wind?
Okay. Thank you all. Thank you very much for taking your time out and talking to us and asking questions and seeing the presentation. Thank you.
Thank
Pallavi,
you
want
so
to
much.
say? Yeah.
Thank you so much for extending your time till now. Take care. Stay safe.
Yeah. Okay. Bye.